Okay. Thank you, sir. Nice to see all of you. I mean, I've been seeing the monitor for the past 2.5 years and talking. So for once, it's nice to see faces and real men. So anterior intermediate uveitis, how do I approach? When I'm seeing a lot of seniors, so it's a caveat that there can be some differences in the way you approach. So this is how I approach. So when you look at it, so take an easy guess. You all know that what it is. So when you look at something like this, something comes into your mind and some person comes into your mind. So you start wondering who is this and what pattern is this. Okay. So in the east, somebody may take another guess. Probably somebody else in Delhi can make another guess. We down south may take another guess. Okay. So you start looking at what do you do next. You start looking at some pattern and some association. So look for any supportive evidence. Look at the eyes, look at the specs, or look at the turban, or what they preach or what they practice. So okay, they talk rationalism, irrationalism, or spiritualism, whatever. No politics. Okay. So this is how you approach. So sometimes it's hinting, so sometimes it's very clinching. So you straight away think. So this is how it is in uveitis also. So spot the pattern. So it's not always that you get a pattern, but like most of the time there is a pattern. Uveitis is like dermatology. So like dermatology is something where you see the see the patient and then start asking history many times. So uveitis also sometimes you spot it and then go back asking history. So spot the pattern and match it with known patterns. These known patterns somebody must have taught you, you must have seen during your internship or residency or in the literature, and supportive evidence in the form of systemic or ocular. Investigate and confirm. I'm getting presbyopic. So treat and follow up. So let's see the anterior uveitis part of it for now. Okay. So not all anterior uveitis have patterns, but there are some characteristic patterns which you can easily pick up. So there are some 3-4 patterns which you can spot it up right away and then start associating it with the diagnosis. Any young adult with a fibrin or organized coagulum is a classical pattern. Okay, you all have been taught that anybody, a young adult coming with an organized coagulum or a fibrin, then you start asking him or her about history of backache or skin lesions, because this you know that is characteristic of a HLA-B27 associated uveitis. So then you ask history related to any of these 4 diseases. So an organized coagulum or a fibrin in a young adult, you start asking about history of backache or skin lesions. So if you are allowed to do one test, then you do HLA-B27 testing. So if any patient comes like this, you are allowed to do only one test, do HLA-B27 testing, do the associated cross consultation like rheumatology or dermatology, and image whatever they advise. So I treat them with intense topical steroids. Initially you might need atropine and probably switch out homide. Systemic and periocular steroids whenever required. In the long term they might need immunosuppressants. We'll see when it is required. So we talk about frequently asked questions and desperately needed answers in these. So does anterior HLA-B27 associated uveitis present posteriorly also? Yes, not very uncommon, because they can present with vitritis or vasculitis. In these situations, you need to treat them with systemic steroids. So initially, you might need only the topical steroids, but if they present with posterior segment, definitely. If it's recurrent or if it's persistent, again systemic steroids may be required. And immunomodulators or biologicals in recurrent despite steroids, or if there is systemic association. So the classical pattern of anterior uveitis is organized fibrin. Another one which we all see is the hypopyon. Hypopyon is as simple or as scary. Hypopyon uveitis can be non-infective if it is in uveitis clinic, or if it's in the retina clinic, it's endophthalmitis. So as per history or ocular systemic signs and symptoms, look at the characteristics of hypopyon. If it's a transient mobile hypopyon, sometimes the patient is sitting up with a slit lamp and lying down in the indirect and sitting up again, the hypopyon disperses. Then this is a transient mobile hypopyon. If you have a convex thick hypopyon, then probably you are dealing with something more severe. Look at the glow. If you have a yellow glow, then it's endophthalmitis. Okay, hypopyon, think infection first and then only non-infective conditions. If it is a transient mobile hypopyon and if you have ruled out infection, then if the patient has history of aphthous or genital ulcers, then you start suspecting Behcet's. So if it's a hypopyon uveitis, suspecting Behcet's, the first thing you try to do is, if you have missed out any subtle vasculitis, do an FFA. If you have a fern-like pattern can be seen in intermediate uveitis also, but like if a hypopyon pan uveitis with an FFA showing occlusive vasculitis, then you're probably dealing with Behcet's. So again, one test if you want to do this, HLA-B51 testing. Hypopyon can also be seen in HLA-B27 associated, so you can test that also. The rheumatological consult, you might start on topicals for the hypopyon, but most importantly, remember that immunosuppressors or immunomodulators is a treatment of therapy for Behcet's disease. Long term, remember that sometimes this patient needs biologicals. We always keep wondering if HLA-B51 is it mandatory or is it enough for the diagnosis of Behcet's. It's a very supportive test. Aphthous ulcers, if the patient typically gives a history of recurrent aphthous ulcers, then probably you are dealing with Behcet's. If you have ocular findings very suggestive of Behcet's, then go ahead, make a diagnosis, and primary immunosuppressive therapy is the treatment for it. You have a low threshold for biologicals in Behcet's. Among the diseases where biologicals you tend to start off very early is Behcet's and JIA. So we saw the fibrin, organized coagulum or hypopyon, the granulomatous variety. If you have a granulomatous uveitis without active posterior segment involvement, you might have some subtle clues like a CRA adjacent to vessel. Dr. Vishali ma'am is here. Like the COTSCON has clearly told us when all to use ATT, and among the ones with reasonable consensus or not a very high consensus is the anterior uveitis presentation. But if you have a broad-based synechia with iris nodules and posterior segment clues, then you can probably think of starting the patient with ATT. But if the posterior segment shows the skip lesions and anterior also has some findings such as an angular KP or a conjunctival nodule, then you are probably dealing with a case of a sarcoid. So a granulomatous uveitis with posterior segment clues of a CRA adjacent to vessel, or if you have an angular KP like this, then TBR sarcoid, one of that. So tests for TBR sarcoid accordingly, and then further tests will be based on what reports these come out. MAN2 itself may be clinching because MAN2 negativity may be more in favor of sarcoid. Start on steroids and ATT or immunomodulators based on TBR sarcoid, whatever the diagnosis is. So when do we start ATT? We used to be running away, not anymore. We know that broad-based synechia and iris nodules, if it is recurrent or if ancillary tests are very suggestive, and if there are some clues in radio imaging, you can start ATT. But especially if it's a recurrent disease and non-supportive lab test, then maybe you can think of intraocular specimen evaluation. Remember that granulomatous anterior uveitis can be a part of a pan uveitis like a VKH or sympathetic ophthalmia. I am not going into the details, but sometimes you can pick up VKH of a sunset glow with a glow like this in slit lamp. So if you have a glow like this with a granulomatous anterior uveitis, then probably you are dealing with a convalescent phase of VKH. Have it in mind. The most interesting about the anterior uveitis is the Fuchs or a Fuchs-like uveitis. A Fuchs-like uveitis can be viral. If you have scattered white KPs all around, then probably it's Fuchs, relatively benign one. But if you have some pigmented ones, the granulomatous ones or the microgranulomatous ones, the high IOP and is seen in elderly, then you're probably dealing with viral. I always take a spot the diagnosis of a viral if you have some corneal lesion. Whatever the lesion with KPs around, then you're probably dealing with viral. And sectoral iris changes, then it's viral again. Look at some subtle scars. It may be close to the scalp line. Then these are zoster scars. Again, it's an indicative of a viral anterior uveitis. Not everyone treat Fuchs with topical steroids, but we treat. I also give steroid cover for cataract surgery because I feel there can be some IOL deposits or CME post cataract surgery. And viral uveitis, ACTAP, diagnose whichever virus and PCR for viruses and treat with specific antivirals. Maintain the IOP. We always have doubts whether ACTAP is a must for diagnosis and treatment of every viral uveitis. See, ACTAP may not give you the positive results, but it really helps out rule out CMV. Because for CMV, you need to treat with valganciclovir or ganciclovir. But for HSV and VZV, acyclovir will be helpful. So it's that way ACTAP really helps in ruling out CMV. If you have clinically more suggestive, treat with systemic antivirals. We treat with systemic ganciclovir if it's proven CMV anterior uveitis, topical ganciclovir along with it, not as standalone therapy. We saw all the classical patterns, but sometimes it just comes like this, not characteristic of any particular disease, so you need to have a broad spectrum investigation and follow up. Sometimes it's so easy, spot it and treat it. So anterior uveitis treat with topicals. If it's not responding and recurrent, then systemic steroids. And in specific diseases like HLA-B27 or JRA, immunosuppressive therapy can be early. For me, methotrexate is the drug of choice, initially at least. A small note on intermediate uveitis. So intermediate uveitis is like us. So people keep telling that uveitis specialists are neither anterior nor posterior, but I keep telling we are both anterior and posterior. So intermediate uveitis, something like us probably. For example, if you have somebody with vitreous floaters alone, you can just watch maybe with NSAIDs. And if there is an anterior uveitis, then treat with topical steroids. If there is vision drop or if there is significant inflammation, if you suspect CME, then you investigate, image, and then treat. Sometimes intermediate uveitis comes with total cataract, no view, then UBM comes into play and definitely picks up inflammation at the pars plana area. So if the vision is normal and minimal signs in intermediate uveitis, maybe you can watch. But if there is significant inflammation with vision drop and if it's unilateral, then local steroid injections may be helpful. But if it's bilateral, systemic steroids and immunosuppressives. Immunosuppressives, especially in children, is the primary therapy for intermediate uveitis in child. Treat the associated systemic condition. FFA nowadays picks up a lot of things, like we saw ultrawide field FFA picking up so many things. If you suspect vasculitis, subtle ones, or neovascularization intermediate uveitis, you can do FFA. And CNS imaging or vitrectomy when you suspect masquerade or non-responding elderly patients. Remember that not always patterns are so diagnostic. Remember, diseases don't always follow textbooks. The original sing, but we have the Singhams winning awards together. Beware of imitations. Always rule out pseudo-uveitis as masquerade. So to conclude, spot and match with known patterns. Sometimes they may be very similar or they may be different. You might wonder what it is. See if it's anterior uveitis alone or part of an intermediate uveitis or pan uveitis or part of a systemic disease. Sometimes they look different or they may be similar. No politics. Like it's wishes for Amrit Mahotsav. Okay. So it depends how you look at it from top, bottom. I didn't mean no politics again. So somebody says I sees the way what the mind wants. Like see, it is ultimately I see the way the mind wants it to see. So fact checking again. That's a popular term nowadays. Thanks, sir. Because initially we were thinking if somebody keeps talking on their own,